You everyone for joining. My name is Tori Kinlick. I will be your moderator for today's session. Today we are going to be talking about pharmacy, identifying and solving the problems in the revenue cycle. Just a couple of quick housekeeping items. Everyone is going to be on mute today, but we do encourage you to interact with our speaker through the Q&A panel. Unfortunately, we will not have time for live question and answer today. However, that should not stop you from submitting any questions or anything you would like to ask Bill. We will be making sure that we address all of the questions and publishing some documentation around anything that gets asked, or even following up with some of our clients individually after this event. So that is it from me. I'm going to pass things over to Bill. Bill, over to you.
Yeah, hi everyone. Tori, why don't you monitor the Q&A, and we might stop in a couple places and see if we can catch some of those.
You got it.
So really appreciate you joining us today. We're going to talk about pharmacy. First of all, a little bit of legal work we always do. This presentation is current at the time it was presented. It might change. You know, government regulations change all the time. So this is presented as of today. And also the CPT codes within this presentation are copyrighted and trademarked by the American Medical Association, and the UB revenue codes are the American Hospital Association NUBIC committee. Neither may be fully reproduced without their express permission. Done with the legal stuff. On to the agenda for today, we're going to review some of the source authorities for pharmacy, review the revenue cycle, which is really quite different than the normal revenue cycle for OR or radiology. We'll examine the CDM and multiplier as the root cause for charge leakage, what impact on prior authorization might have on your high-dose chemos, understanding clinical dosages, and then we're going to look at some of those self-administered and the JW modifier. Today, we hope you can learn to use the modifier appropriately, understand the steps to audit a pharmacy claim, able to state why carve-outs and prior auth are important. And remember, everything we're talking about today in the 636 revenue code is considered a carve-out for most commercial payers, so that you will be getting some sort of a percentage charge or percent of fee. And so that's important to pay attention to that. So let's just get right into it. Overview, the pharmacy has a very disparate revenue cycle. It does not look like the revenue cycle for any other department. It is all based, everything in the pharmacy is directed off one benchmark, and that's the NDC number. From that is the dosage, the HCPCS codes, everything's off that NDC number. Review the self-administered medications, because still 10 years later, we're still struggling with that. And then a JW modifier, and then charge capture concerns. As we move now on to your source authorities, I've listed them all with a link in the presentation, the FDA landing page, which is a great resource for looking up drugs. There's an NDC lookup table. So if you know the name of the manufacturer and the package size, you can find the NDC number. 340B we will not be covering today because it's a week-long presentation in and of itself, but HRSA is where you can find all the program requirements. We'll talk about self-administered medications and again that JW modifier. When we look at the charge capture complexities, in particular is pharmacy, because when I was in just straight consulting, looking at revenue integrity and return on investment, with a consulting firm and with the accounting firm, we went to one place and one place only. If we wanted to find charges that were missing that could make a difference to the bottom line, we went to the pharmacy because it is complex and it does have a lot of nuances. And it starts with the fact that the NDC gives you your billing package size and what have you, and then it goes into the order and the dispensing, which is fine. But then that dispensed dose will not have the same units on it as your billing dose. So that's an issue. If you're in an Epic environment, you may struggle even more because of the concept of shells, where a lot of the individual drugs go into a shell and are billed out that way. Wastage and credits continue to be a problem nationwide, and every institution I've been at the last 5 years, wastage is still an issue when I go in and I audit them. So when we look at the pharmacy revenue cycle, it's very different. it starts with the purchase and inventory, Ms. Cardinal or whatever wholesaler you have. And then if there's a 340B placed purchased, it's placed in a virtual inventory. And that's one of the 340B requirements, is that you keep that separate, that inventory separate from the remainder of your dosage pharmacy. So it goes into a virtual inventory within their system. They have to reconcile that item. Is it a new or replacement? Did it come off the replenishment list? If it's new, they need to add it to the CDM. Map those pharmacy items over in a pharmacy module to the charge master. It is at that point the first error occurs. We frequently see the mapping between the pharmacy module and the charge master being off. So that's your first error area of concern. Then you go in from the charge master and you do the mathematics to get the charge to change the dispensing unit to the billing units. That's your second area of failure. And then the charges are placed on the claim. It goes through a scrubber and the claim goes to the payer for reimbursement. Now here's when the charges go on the claim. It is imperative that if this is a drug that requires authorization, it has received an authorization prior to administering it. So up before the charge master is the administration. And if there's no authorization, then everything after that is really quite pointless because you're not going to get paid for it. The claim will go to the payer for reimbursement. And at that point, we're going to analyze the spend or the purchase file versus what we charge. Did I charge more than I bought? Did I buy something that I never charged for? So we start to look for those discrepancies, go back to the root cause, and then back through the cycle again. So we'll start with that billing, that NDC unit. The National Drug Code, which can be found on the FDA website, is either 10 or 11 digits. The older ones are 10, now they're 11. And the 11 digits are in a 542 layout, where the 5 digits, the first 5 digits are the code assigned by the FDA for the labeler. The second 4 digits is the actual product. And then the final digits is the package code. So this is very important because a lot of charge masters, I'll go in and I'll see the NDC was something from when they purchased three purchases ago. It is not the one on the vial, and billing may require the NDC on the vial be represented on the claim. So that's a big issue, especially for Medicaid. It's the NDC that's actually administered and not the default NDC in your charge master. So that's a concern, and with barcoding and scanning, it's getting a bit easier. Here's just a graphic example of your labeler code, product code, and package code. One example is the NDC requirement. Is that the correct code? And here's just a statement from a mayor group, which is also we see in the Medicaid manuals, in the Medicare manual, which NDC was used. Can I pick another NDC under the outpatient drug claims and bill with that? And the answer is a resounding no. The NDC submitted must be the actual NDC on the package or container from which the medication was administered. So now more and more on the labels, we're starting to see the NDC number, so that when they create the label on the vial or on the IV bag, there may have an NDC number. If not, you're going to have to scan the actual vial or syringe or whatever, and that becomes a bit more difficult. So you're going to need to operationalize that. Under the Affordable Care Act includes provisions about state collection of data, and because of those federal laws, there are several NDCs linked to one HCPCS CPT. CMS deemed the use of NDCs critical under PPACA and identify the drug manufacturer in order to do the rebates. So again, this is a big thing, this NDC number that was administered getting onto the claim, because the rebates are part of this. And one of the Office of Inspector General consistent finding is overpayment for rebates to the different states. So if you have 340B, that should be truly it. So now we're going to move from the NDC to another complex area, which is self-administered medications. And I always get this, well, my wife or husband is in the hospital and he's too sick to take his medication, so why are they self-administered? The nurse had to give it to them, or the doctor had to give it to them, and that's not the point of it. The point is that there are several requirements for a medication to be covered under Part B Medicare, and Part B Medicare covers very few medications. That's why you have your Part D. The program only covers drugs furnished incident to a physician service, provided the drugs are not self-administered. So that means if it's self-administered, it's going to be excluded from Part B coverage and a liability for the patient. Self-administered is not by the patient, but according to how Medicare population as the whole uses. So can 51% of the population take this medication? So if it's a tablet, yes. If it's a cream, yes. If it's a sub-Q like an insulin, yes. So it's not how the individual or physician choose to apply it, it's how can 51% do that. Determining if it's SAD or not is pretty straightforward. It has to be more than 50%. And they actually said in the section, chapter 15, section 50.2 of the Medicare Benefit Policy Manual, excuse me, absent evidence to the contrary, all drugs delivered intravenously are not self-administered. That means they're going to be covered under the Part B Incident 2. Absent evidence to the contrary, presume all drugs delivered by intramuscular are not self-administered, also going to be covered. So when I teach this class on self-administered, I always say, if it's a big needle you're using, it's probably going to get paid separately. If it's a small needle, it's going to be self-administered. Drugs delivered by subcutaneous injection are considered to be self-administered because 51%, and that's going to be your Lovenox, your Imitrex, your insulins, all of that. When I decide whether to bill for self-administered, for many, many years, the government said you had no choice. You had to bill the patient for it. And the way you were to do it was use Revenue Code 637 and HCPCS Code A9270 on a wholly covered claim. There were some Medicaids that wanted 259. And then the question kept coming up. I'm getting patient dissatisfaction from billing them. I'm billing them $20 for a Tylenol. They can get an entire bottle at the local retail pharmacy for $2. So how did the Medicare beneficiary know this is excluded? It happens through a communication called Medicare and You. It's a book that every year Medicare puts out for traditional Medicare saying what's covered by the program and what's not. So most people, when I teach Medicare at the end of the year, I go through the 2021 section and show what is. If I use First Coast, and hats off to them for providing this good billing data, they are a MAC in Florida. They tell you have to use Revenue Code 637 and A9270, which is a non-covered item or service. Modifier GY is used to show that it's statutorily excluded. So on a wholly covered claim, you're going to need 637 A9270 GY in the non-covered column. A reason you will see the GY modifier precedent and it'll hold the beneficiary liable. When it comes back on your 835, you're going to see reason code 31324 and 31947 if the GY was not present. The important thing here is for your self-administered medications, be it in the ER, outpatient clinic, outpatient surgery, or even observation, an ABN is not required. You never need an ABN for something that's statutorily excluded, but you are given the opportunity to provide a voluntary ABN, but it is not required. Charges are non-covered, so do not submit them as covered, meaning these 637 and the A9270 GY must appear in the non-covered column on a wholly covered claim. Otherwise, send a single claim in that's entirely wholly non-covered and it meets the same criteria. When you bill for it, patients react negatively due to that pricing. So one of the things that happened recently, not too long ago, is the OIG said in alert guidance policy that hospitals will not be subject to administrative sanctions, meaning OIG will not pursue this if they discount or waive that Medicare beneficiary owes for non-covered drugs. For a long time, it was considered to be a waiver of copay or deductible or other matter under the Medicare program. OIG said, okay, we're not going to pursue this. It's a huge client dissatisfier of the Medicare population that are voting members of society. We're not going to do this. But there are criteria. And those criteria is that the hospitals must uniformly apply their policies regarding discounts or waivers on non-covered drugs, regardless of the beneficiary diagnosis or type of treatment. Hospitals must not market or advertise that they're going to do this. Hospitals must not claim the discount or waive amount of bad debt or shift the burden of these costs to other payers. So basically, if you're not going to bill for self-administered drugs to this payer, the understanding of the OIG is you will not do it for any payer to provide ensure there's no cost shifting. However, having said that, that's a gray area. Many commercial payers will tell you that they will pay for self-administered drugs within your contract. So outside of Medicare, you are required to follow the contract in order to make sure that you followed what you legally agreed to. So that's it. While the OIG says not to do this, if in fact there is cause within your contract to do it, then you have to abide by that. And they said nothing in the policy statement requires hospitals to discount or waive, meaning there are hospitals that still charge for it, so that's fine. We're going to go on now. Tori, there's no questions. Good. We're going to go on to the JW modifier, and this one has been rather nasty to implement. First of all, where do you find the regulation? It's under discarded drugs and the claims processing manual, chapter 17, and I've given you that link. The JW modifier is not a CPT modifier. It is a HCPCS code modifier, and it is for discarded and eligible for payment drugs, meaning you can have a discarded drug and you can put JW on it, but there's no payment going to be made for those drugs that are not eligible as separately payable. They must be single dose in a single package. So what happens again? We have the NDC number that was provided. So say you have in your charge master a drug that comes in both multi-dose and single dose, and you have the NDC number for the multi-dose, which is not eligible for wastage, and you put that on the claim when in fact it was a single dose. So once again, we're up against that NDC number, making sure you do it right. It is for the amount indicated on the vial or package. And this comment came out as the JW started. Amgen routinely puts a little more in their vial of Epogen to make sure the entire dose can be obtained from the vial, because you've got your syringe length and a little air bubble. So they're a little bit higher than in the vial than what is. So people were starting to charge more than was actually labeled for the vial. So you can only go up to that amount. And the modifier is never required if no discarded drug is being billed to any payer. So if you decide you're not going to do discarded drugs to any payer, you don't need JW. The JW does not apply to drugs or biologicals in a rural health clinic or federally qualified health center. The modifier applies to all separately payable drugs. So if you're looking for a separately payable drug from Medicare OPPS, you're going to look for a G as in girl or K as in kite status. And N is a package service. So while you may have a drug that is single dose, with an N, you cannot expect reimbursement. And so therefore, most people don't put a JW on it. You should not be used for the actual dose of the drug if it's less than 1 HCPCS unit. So they basically said that prior to January 1st, 2017, if you contained discarded drugs and didn't use the JW, they were going to review it. The drug discarded should be billed on a separate line with the JW. So basically, you're going to take the NDC number and the HCPCS for the full single dose, and you're going to display on line number 1 the amount you administered based on the order. On line 2, you're going to use the same HCPCS code with the JW modifier and the price for that. The price for both the administered and wasted should not exceed the total price for the vial that you're providing. So that's one of the tricky parts within the billing system. It does apply JW to all separately payable drugs, status G, which are pass-through, and K, which are non-pass-through, but separately payable. And again, you don't need to use JW if you're never going to do it. Eligible and participating 340Bs are not exempt. That was a wise tale out there for a long time. If I was 340B, I didn't need the JW because, you know, so I may have a UD modifier or something like that on it. That's not correct. You are not exempt. So how do I choose if something needs a JW? One, I'm going to look at Addendum B and select all the Gs or Ks, or within the Charge Master knowledge VitalWare has. You're going to then subdivide all those Gs and Ks by those that come in single dose versus multi-dose. And I'm going to then filter it out so I only have single dose Gs and Ks. Those are the ones that will be eligible for the JW. And when you do this, you're going to actually see, you know, when it first started, oh, I'm going to have hundreds and hundreds and hundreds, and it ends up being 25 or 30. If I look in Vital Knowledge, I can do the entire J code range, 0-100 through J999, and I can filter it for G or K, and I get a list that I can export of just the G and K drugs to start. If I go further with that G and K, I want to look at those that are just single dose. And so I can export those NDC numbers. And what I usually do in the CDM to make it easier for the future is I will start either put at the end of the name of the drug or at the beginning SD for single dose in like the Charge Master description. Those are going to need a billing unit conversion as well. So we're going to move on now from the JW to the billing units. Are there any questions that anybody has? I'm looking, I'm not seeing any. Okay, we'll move on to the billing unit conversion. This is something, this particular slide is responsible for most of the charge capture errors within pharmacy. I found in one place where they forgot in a shell, they had it in a shell of 250, so it wasn't converting the multiplier correctly. And it ended up to be $7.4 million over 5 months after an epic conversion. So, I mean, this is the area, if you're going to look for lost money, this is it. In terms of charge leakage, this unit is number 1. And the reason it's number 1 is that when you put in a drug and you do the multiplier, you do not have the billing department or the patient financial services print a mock claim. Therefore, if you don't print the mock claim, you will never know if the billing units came out correctly. So, I mean, I work for the big accounting firms. This is where we always go. The NDC is the ordered dosage to an NDC dispensed dosage. So that's what the pharmacist is doing within the pharmacy. They're taking the order dosage from the physician order or mid-level order, and they're putting it into a dispensed dosage. And that's what's going to go on the label. However, the NDC administered dosage has to match the dispensed. So you've got ordered equals dispensed equals administered. And the way you know that is most places the nurse uses a scanner, a barcode scanner, and scans the patient, scans the order, scans the drug, scans their badge, and then back to the order. And that loop ensures it's right patient, right dose, right time, right everything. However, past that point, it's a free-for-all. The conversion is based on math, and that sometimes can be done by information services, can be done by pharmacy, but it's very complicated, especially with the JW. And I don't find a lot of people other than finance that understand how to do the multipliers. Here's an example, a very easy example. So in the ER, chest pain, they're going to get 4 Zofran, 2 morphine. That's just a standard dose. The package on the Zofran is 2 milligrams per ml. There's 2 mLs in the vial, so there's 4 milligrams total. The J2405, I ordered, dispensed, and administered 4 milligrams, but it was 1 vial. So a lot of times on the bill, I'll see a billing unit of 1. When in fact, when you look at the HCPCS code, it's per 1 milligram. So when J2405 goes on, it should have 4 units of billable on that UB04. Failure to do that would give you an underpayment. Now, obviously, a Dancitron is an N status and you wouldn't do it, but I just used it for an easy example. Morphine, however, J2270 says morphine up to 10 milligrams. So if the order dose was the 2 milligrams, the dispensed dose was a 10 milligram syringe, then you're going to go less than 10, so it's going to be 1. Are you going to use wastage? The answer is going to be no. First of all, it's an N status, and second of all, the HCPCS unit cannot be less than 1. So it's still 1. What I see, though, is nurses carry the syringe around for the patient who's having chest pain, keep it in their pocket, and do like 4 doses of the 2 milligram. You know, you can't charge a 10 milligram each time. It's single dose. It has to be thrown away. The key to ensure the NDCs on the shelf has the correct HCPCS code at the time of purchase. So as it's coming in, what is that NDC? Does that NDC match our charge master? Is that charge master NDC from Vital Knowledge, does that match the HCPCS code? So a lot of times, especially newer drugs, they'll have a interim period J code or C code or otherwise unspecified code, and then mid-quarter they'll change it to a code and you're missing reimbursement. Some software systems have a high and low dosage range to capture billing units. I know at Vitalware we do. So when our charge capture tool, we're looking for units under the expected or over the expected, but you still have to audit it. So when we look at software, most facilities are using a pharmacy software. And many embedded softwares have managed the order, dispense, and medication safely, such as Epic Willow, Cerner PharmNet, and Meditech PHA. These are all the pharmacy systems. And the way they're set up, either the pharmacy system overrides the charge master, or the charge master remains the constant unless it is overridden. So there's a number of different gyrations from the pharmacy module to the charge master. Price overwrites, unit overwrites. You have to kind of map out every charge master and see what happened. After the charge is created, there's a mathematical algorithm that converts it from a dispensed and administered dose over to the HCPCS code. So the importance of the revenue and usage then becomes, I ordered 100 units of this and I've only billed for 1. But I see when I go back in my orders, I really have dispensed 100 units. So this is where your revenue and usage report really is key. You look at your high acquisition cost medications, your high volume medications. Look at departments where you know there are going to be issues, infusion centers, rheumatology, chemotherapy. Manually do the math and convert a vial to a billable unit and see what's happening. A lot of times they will send over the drug or send over a drug that's been pre-made to a cancer center, and the patient can't receive it that day. And where's the credit? So that's the other thing I see. So the first step is the NDC and the HCPCS, do they correlate? And I find out in chemo quite a bit, because these J codes change, that in fact, the NDCs a lot of times don't match, or as I found yesterday in a review of a CDM, I found 6 J codes that had expired in 2018 that were still connected to the pharmacy. And that's what was coming over on the bill. So does that NDC show you the right HCPCS code? That's step 1. And down below, you see Rituxan, an NDC number, and it tells you it's J9311 for that NDC number. So that's how the first step, where you go from NDC to CPT. Second is a review of the revenue and usage or the spend file. So you take a copy of the spend, and I do it from 60 days prior because the shelf life is usually no more than 60 days. Review the charge revenue and usage, how many were charged, and deduct the spend from that. Then you take whatever that amount is and deduct whatever's still on the shelf. So it's basically an auditor's way of a physical inventory. What did I buy less what's on the shelf, and that should match what I charged. If there's a large difference, then there's either lost charges or overcharges, and that revenue and usage is going to be based on your billed units. So is that the cause of it? So for example, here's an embedded calculator. So you're looking, we're back to that ondansetron thing. 3 milligrams administered, 1 wasted. It is this end status. So the JW will not show over in the wasted units. We see the 3 here, the 1 milligram, and then the 3 units are billed. However, with liposomal daunorubicin and cytarabine, that's a much different story. Here's the G code, which says it is separately payable pass-through. And then you have the J9153 is what the NDC number coordinated to. And we had 100 milligrams order, and it comes in a single dose, and we wasted 20 milligrams. So the dose administered was 100, the dose wasted was 20 milligrams, and we did 1 vial. The 1 vial is 120. So in this case, for the bill, I would have 636 revenue code J9153 with a billing unit of 31. On the next line down, I would J9153 with a billing unit of 6, but that J9153 is J9153JW. So you're going to have 2 lines, one without the JW and billable units of 31 and the according price. And then the second line is going to be J9153JW with 6 units billed. So that's how you do it. The next step we're going to do is actually audit it. I see Revenue Integrity really getting specific with their auditors. There are 2 locations you can really audit. One is a pre-bill itemized charge. And then the other one is using your actual claim, the 837 UB, and see the post-bill charges. Did something happen in that? Did I actually charge a dose of 100 units and a post-bill charge on the claim only was 1? The pre-bill allows for correction of the claims prior to the claim submission, and the post-bill means that it will have to be fixed. Now, there's 2 places you can do a post-bill review. I like to do it before the scrubber, meaning that the system, be it Epic, Meditech, Cerner, CPSI, whatever, the system generates an 837 that is then sent over to a bill scrubber. I like to grab that 837 because it should have all the late charges on it, have all the coding, everything should be good. And I like to grab that because I still have time to fix it in the scrubber. So I like that place to do all the charge capture. But you can also do it after the scrubber, but then you have to do a rebill or adjustment claim. Pharmacy pre-bill edits are particularly important because of the high dollar drugs and the high complex biologics that need chemo administration. To this day, for injections and infusions, I find that people are still getting confused what can be a chemo infusion or injection and what has to be a regular medication infusion and injection. Just because it's given in chemotherapy infusion centers does not make it a chemo. There are very specific drugs that are designed as being highly complex biologic or true chemo. And I've given you some of the targets and charges in this Noridian document. So there are many drugs, and if the drug doesn't appear on the charges, then potentially the drug was missed or you put the wrong infusion charge on. Either way, it's going to result in a lost charge or medical denial. So pre-bill edits are used to illuminate when a code pair is present and the charges to ensure the claim. And here's an example, albeit very small in your deck, you'll be able to see it better. But this is rituximab. And this is a rule that says if I have J9312 on the claim with a billing unit less than 38, which is the minimal therapeutic dosage, and a patient who's over the age of 17, stop it. Flag this rule, trigger it, put a stop bill on it. There's something wrong with this. And so you're able to catch these inappropriate billing units early on. So, and we just did over 17 for this example because 18 is an adult. Your vaccines, again, here's the administration codes. You look for the vaccine examples. When I do pre-bill edits, I'm going to look, does the vaccine have an administration? Does it have a drug? So in the previous slide, the way the pre-bill operate, it can trigger a target and administration. In this case, the trigger is G009, and these are potential targets. The advantage of a pre-bill edit is significant because the rebilling threshold for a claim is high. So unless you've missed a huge high dollar drug, the likelihood of rebilling is low. You're going to have slow leakage. That's what I just kind of small leakage over and over and over again. In order to rebill, you usually have to cancel the claim, wait for them to return the money, and send in a corrected claim, which upsets your cash flow. So being able to do this before the claim goes out really increases the probability of lessening that lost charge opportunity. Drug thresholds are absolutely key to this. Drug for immediate remediation and allows for comparison the NDC. So if I want to just do one mock claim for, say it's coming up on 2021, and I want to look what my charge master's doing, I'm going to put in a specific unit on every single G and K and see if it comes out right. Is it coming out right? And I just make a mock claim. So I charge up a bunch of drugs on a mock claim, mock patient, and make sure the billing units come over. And that's what should be part of your annual CDM review. To do this is to print those stat claims. Disadvantages is that you could have multiple drug charges for the same medication that would exceed the multiple medically unlikely edits on a single date of service that would not be caught. So say you accidentally triple charged it and the units came over okay, it exceeded the MUE, but it wouldn't be caught because it's pre-bill. Billing units behold threshold may not always be caught because sometimes that conversion happens at the time of creating the claim. So you've got a lot going on with those pre-bill. So if I do a 837 before the scrubber, now that was straight charges. Now we're going to move to the next step along the train line, the pre-bill before the scrubber, and it provides time for the correction, just like the claim, the charge level. It allows for definitive measure of below and above therapeutic ranges because this is what's going on a claim. So that should have been calculated by that point. Allows for detection of billing units above and below and the MUE because this is a generated claim out of your system and still time to put a bill hold on it before it hits the scrubber. So the 837 before scrubber offers quite a number of advantages. The disadvantages is if you're at min days, the last minute work to fix the charges may not happen in time, and there's still charges may be in play. Late charges are a problem everywhere, and you may have a higher volume caught in the 837 pre-scrub to work, meaning more FTE use. The post-bill side still shows you those patterns of behavior. It's going to show the missing late charges that never got on the claim at all. Identified triggers and targets are much easier because they're actually submitted to the payer and they were paid. So you know that if it wasn't on that claim, you've missed it. And easy to identify the drugs below threshold because it was on an actual claim. The disadvantages, as I've said, rebilling is expensive. There's a threshold for that and it's time consuming. The UB04 or 837 doesn't have any detail behind the charge. So it's just CDM number description. It's just a HCPCS code and a revenue code and a price and a unit. And charges can be rolled according to the revenue code on inpatient claims. So all drugs are going to one revenue code, 636, with the total price. Doesn't really matter what the units are because it's just it's going to be paid on DRG. The advantage of real-time versus manual. So in real-time, HFMA stated that 1.5% of the bottom line revenue is lost to charge capture overall in a facility. A great preponderance of that is in the pharmacy and device area. Real-time itemized charges that pull in 100% of those charges are going to allow you to find patterns of behavior and fix it much sooner. Targets and triggers can do this in an automated way. So you would spend days, weeks, or months trying to do this manually for a couple of days, where a system can do it in a matter of minutes. A real-time review of administration to medication association for lost charge. Where I have a drug on a claim but no administration. Is that a drug that should have had credit? Or is that one that we just forgot to put the administration? And what we find a lot of time is on patient bill, there's an overcharge because the patient should have been credited. Therapeutic thresholds are taken into account, and it does catch that revenue. So if I look at a general accounting audit cycle, this is a standard accounting audit cycle. When I became an auditor, this is it. They set the standard, whatever the benchmark might be. I measure the practice against that benchmark. I compare the results to the standard practice, and I change the practice and then re-audit it. So for example, this is infusions and injections, and the standard is I must have a start and stop time. I measure that practice against that standard, and I find that 53% of the time, the nurses fail to put a stop time on it. The start time is always there because of the medication administration scanning, but the stop time seldom is. Then I compare the results to the standard and I say, you know, this 53% is too high. I need a root cause remediation process, maybe a Six Sigma group, and then I re-audit it. For pharmacy, it's not any different. I'm going to look at that revenue and usage, purchase items, and NDC number, and I'm going to make sure the HCPCS code's right. I'm going to measure the NDC against that HCPCS code and the billing units. So I've got this benchmark, I've got the standard. Now I'm going to compare them on the units to the claim dispensed, making sure that conversion factor's right, identify any aberrancy, and then re-audit it with stat bill reviews. And again, the key to finding pharmacy lost charges is providing mock claims to test those charges. The benefits for auditing is it allows for over and under identification. And remember, an overcharge is a compliance issue. Allows for pattern of behavior that might otherwise be missed. So say, example, you are having a problem with rituximab and Blue Cross of XYZ state, and you look and rituximab has a local coverage determination or payer guideline for authorization, and you see that this is one that you're failing to get authorization on. Demonstrate charging inaccuracies with high dollar drugs. Allow for determination of wastage in the application of JW modifier. It is required as part of a compliance plan. Ongoing monitoring and auditing is required. It increases your patient satisfaction because they will be the first to call the patient financial services and say, I was never on that medication. Why is it on my bill? Essential and new charges are set up to detect inaccuracy, and then you've got to break down the silo between pharmacy and rev cycle. Many pharmacy groups have embedded revenue cycle there, but they don't connect with the main revenue cycle for the facility for all other things. And so that disconnect has been found over and over and over again to be a problem. So what you want to do is connect pharmacy, whether they have their own rev cycle or not, to the main rev cycle so that they can see patterns of behavior in other components of the facility. Consider the universe of the population being examined. How many records should I review? Do I have a seasonal variability? I mean, my flu shots are going up, and when we get a COVID vaccine, that's going to fly through the roof. What is the compliance component? Do I require RAT stats and statistical reliability and precision be done? Do I need a statistician? What are the patterns of behavior? Is it only this department that it happens in? Is it only the evening shift that is not getting their drug on? What is it? Will the selection be made by software? Okay, that's going to do 100% of the charges, but if you're doing a manual audit, you're going to want something easy like the nth selection process. So say I want 100 records total. You can take the digits of the month, now being 11, and you audit every 11th one until you get to 100 selected. Therefore, you take the first 3 11s, so 11, 22, and 33 on Monday, 11, 22, and 33 on Tuesday until you get to 100. And that's just a randomization. You're going to compare step 3 results against the standards. You're going to select those random records. You're going to example the vaccine, the patient receiving vaccines per medical guidance. That's a big population health and primary care. That is an ARQ quality measure. Select the portions of patients that were identified as requiring the vaccine and how many received it. Once the results of the comparison between the benchmark and the chart findings are determined, then you can make a hypothesis. What I see people all the time jumping to conclusions because they had something similar like this in the past, and it really isn't the same thing. So then you change the process and re-audit it. If you don't re-audit it, you will never know if the change process is there. And you must re-audit it 2, 4, 6 months down the line because, in fact, people go back to their original behavior as the norm. So it's going to go back. If you have a Six Sigma team in your facility, I recommend they become involved with pharmacy and the audits. The easiest way I find errors is by the 5 whys. I learned this during my training with Six Sigma. Yes, it's the why question 5 times. The first why may give you an answer, but it's not the finite answer. By the time the 5th why has been asked, you are usually at the true result. So here's an example. You note that one found an IV contrast that should be billed by milliliters. You ask why is only 1 unit on the claim? And because it was auto-charged by the injector. Why was charged but not in the correct amount? Auto-charging. Because the charge fires based on the activation of an injector that doesn't have anything to do with the amount. Why was the wrong unit assigned at the time of the injector? Because the radiology system set it to flow to the CDM based on the injection, not the dose. Why did this occur? Because the math behind the mapping from the radiology CDM did not charge by the CC, but charged by the vial. Why was the math wrong? They failed to audit after originating the charge and mapping in the system. So this is an actual example. I did find this example, and every one of their contrasts were billed as 1. And so we went ahead and looked, and this was the issue. But in the beginning, the answer was, oh, the auto injector does it. So that has nothing to do with this claim. It's just the auto injector. When I went through 5 whys, it had nothing to do with the auto injector and had everything to do with the mapping. You remediate it, so the corrective action plan was put in place, and then I re-audited it for a period to come, make sure. So a simple audit of purchase and charged also can illuminate charge capture. And we talked about this before, but basically I start with the purchase quantity, convert the entire purchase quantity by NDC to billing units. So what's my total billing units? And I'm going to subtract the billing unit charge from the claim from that. And that should be the billing units that are left on the shelf. If it's not, you have an aberrancy. And so what is that caused for? What's the difference? Is it due to wastage we didn't charge? Is it a conversion multiplier? Did we fail to return the medications for credit? This is where you look at your root cause. So when I put all this together, I've given you the source authority. I've talked about the JW modifier, SAD medications and billing units, the use of software, and the importance of random auditing. And this is what I take away from the pharmacy. If you can't explain it, say to me simply, then you don't know it well enough. And that's the key with pharmacy. If the pharmacy or the charge capture team or the billing people cannot explain it in simple fashion of what's going on, then they likely don't understand the actual processes and what has to happen. And finally, before questions, make sure all of this is written down in a policy and procedure. Job aids are great. They give examples of billing conversions that you can give to the charge master team. Making sure you understand your payer contracts, which one of those have carve outs, which ones require prior authorization. So a lot of times in pharmacy modules, I'll see payors that require prior auth listed or in the notes, or I'll see, you know, errors that have happened in the past. Somehow it's identified. So I'm going to look at the Q&A and say, how are self-administered drugs identified in the charge master? They should be 637 as the default. And so the first thing is you would then have an ancillary revenue code for those payers who don't want it. It's probably Medicaid 1-259. The other thing is, what if an oral drug J or Q HCPCS codes, are they exempt from the SAD? No, actually they are not, because they can be taken by more than 51%. However, what I do with that, because it has the J code, I put that in the wholly covered claim. So I use 636 and the J code on the wholly covered claim. They're not exempt from the 637, because if in fact it denies as payer as liability, patient liability, then you move it over to non-covered. So there are specific examples of that within the claims processing manual and also within most of the MAC instructions on how to do that. Then the next question is, what sort of documentation is needed to use JW? I heard the amount wasted has to be documented by the clinical staff on the patient's record. That is the benchmark, that the amount given and the amount wasted are in fact on the clinical medication administration record. However, the medication administration record seldom allows for wastage. It just shows the administered amount. So the ordered and dispensed, I mean, if you had to go back and audit it, you could, but generally they want to see the wastage on that. But most medication administration records don't have that. So what happens when one is set to JW, that drug is set to JW, many of the systems, when you put in the amount administered, another thing comes up that says, was there any wastage, yes or no? If you say yes, then a pop-up note comes up and you're able to do that, enter the amount wasted there. You were not going to be able to do it just from scanning, however. Nobody can do that. So that's pretty much all the questions we have. If there are any others, please go ahead and type them in the chat box. I think we have maybe 6 minutes left to be able to answer your questions.
Yeah, great. Thanks, Bill. And yeah, we're going to leave the Q&A open for just a couple more minutes here. And in the meantime, I will just go through some of the I'll just go through my kind of wrap-up spiel here. And so feel free to type your questions in and we'll have a chance to get to them before we wrap up here. But thanks to everyone who joined today. I hope you all found this session to be enjoyable and informative. If there is any information that you saw that you had questions about or wanted to dig deeper into for those VitaWare clients, feel free to reach directly out to your CSE. Or for those of you who are not clients, you can just come right on our website. We can chat with us there, or you know, if there's anything that you wanted to get a demo on, we can certainly set you up with that as well. Feel free to follow us on Facebook and LinkedIn, where we are constantly posting our latest and greatest content, along with sharing any upcoming webinars we've got. And it looks like we did just get one more question in here, Bill. Do critical access hospitals report waste to Medicare?
They are not in the excluded population. And you will have to look at your guidance, Karen, to find out whether you can do this within method 1 and 2. So they were not excluded, but most critical access hospitals do not do the JW modifier. At least there's not been one I found, because they just don't tend to build a wastage to anyone.
Okay, and we just have another minute or two here. It looks like we got one more question in.
Yes,
for Bill.
yes. Inhalers can be administered by more than 51% of the Medicare population, so they're absolutely self-administered. Albuterol and Pentatab, all of those are definitely self-administered. Karen, are you in Ohio? If you're in Ohio, just say that, because what I would recommend is that you go to the MAC regarding the CAH, because different states have it. I mean, most people do not do critical access. That looks like about it, Tori. Oh, I have another one. West Virginia. Trying to remember. I don't know of a critical access in West Virginia, but I will look that up and make sure and get it over to Tori and make sure we have your email. Tori, you have Karen's email?
Yeah, I'll be able to track her down.
So I will find out the source authority to confirm that.
Sure. And it looks like we did just get one that came in through the chat window here. Bill, what are your thoughts on charging injection charges for self-administered drugs? An example would be insulin.
Where is this?
This is in the chat. So yeah, not the Q&A window, the chat window.
No, where would that even be?
That's at the bottom as well.
Yeah, I can't read that off again to me.
What are your thoughts?
Here's the chat. Here's the chat.
Yeah.
What are your thoughts regarding charging injection charges for self-administered charge? I mean, I'm not fond of it because it's self-administered. It's excluded. It's excluded from coverage. Therefore, subsequent amounts due to most of the MACs, they're saying it's excluded charges as well. So anything that is statutorily excluded generally doesn't have the administration charges, because it also would be statutorily excluded. So most MACs will tell you not to charge that.
Okay, and if there are no other questions that do come in here, then for everyone who attended today, we will be sending out a follow-up email that will have the link to the recording from today's session, along with the deck that Bill ran through. And also within that email will be all of the information on the CEUs. This session was approved for both a HEMA CEU as well as an AAPC CEU. So that information will all be sent out following the event. And if for some reason over the next 24 hours or so, you're unable to get that information, just reach out to us on our website, and we will make sure to follow up with all the appropriate documentation. Looks like one more question.
One more, and yes, according to the PPAC Affordable Care Act, it is in fact incorrect. Whether it was billed correctly or not, the documentation is going to support an NDC that could be a rebate NDC. So therefore, if that NDC number in the MAR doesn't match the product that was given, it will be a problem, because your rebates are associated with the NDC that was ordered and dispensed. And that's it. I hope this was a good session for everybody, and wish you all a happy holiday next week. And Tori, why don't you close it up for us?
Yeah, great. Thanks again to everybody for joining, and keep an eye out for a follow-up communication from us. And I echo what Bill said. I hope everyone has a happy holiday, and please stay safe out there. Thanks.